Okay,
All righty.
Dr. Lichten, let's hear about the relationship of testosterone and diabetes. I know there's a big one.
Okay. This is something I've been working on for more than 30 years. Matter of fact, I told you I did the presentation for the A4M and in 1999, their quote grand rounds. And the data has continued to support us in the literature. The concept was put forward in the 1940s by Jens Moller in Denmark.
Oh, yeah,
And he
I
had
read his book.
10,000 cases of diabetes in both men and women, and 250 physicians working with him. The problem was that the pharmaceutical companies they had an issue and took him to court. And after 4 years, he was able to be freed of charges by treating the magistrate's sister. But his wife had died, and then he died a few years later. But the point he made was diabetes is an inflammatory disease, and it was not as toxic as it is now. I started in the mid 80s using testosterone on a number of my diabetic men, although I'm a gynecologist, and the results were very good. One of the men is in his 60s. I've got slideshow showing that we dropped his hemoglobin A1C from 15 down to 7. And he's 63 years old, works at six pack. It got to the point where his internist said, I can't write prescriptions for you anymore for testosterone. I have to write for you for diabetic meds. And I've been on testosterone since my 40s. And down here in Florida, going through the Cleveland Clinic Foundation, could not get one of the 8 doctors I saw to write for testosterone. They said we're not allowed.
Wow, and you're a doctor yourself. What a
Well, I have another. I
superiority.
had to get another doctor outside of them, but they said we will not write for it. So, and I've had discussions with the director of the Wellington program down here also. We don't do it. I said, but if you look at the literature, 1996, his name is T. Hughes Jones, and he just published in October of 2023 the Society of Endocrinology for Europe, and he's the professor at the UK, professor emeritus, and considered the most knowledgeable endocrinologist in Europe. He wrote, as I noted before, 500 men from different countries over a period of 2 years using just 200 milligrams once a week. He dropped their A1C 2.75%, which means he reduced their cardiovascular risk by almost 2/3. Now, I've used testosterone, but then I added other anabolic steroids, and in my data it shows, and in the book, in both the insulin and the blood sugar. So over a period of 4 months, we got a baseline glucose tolerance test and then added one product at a time. 200 milligrams of testosterone, then 25 to 50 of nandrolone, then 10 milligrams of intramuscular stanozolol, and every one of the A1Cs in this period of 5, 6 months dropped from 15 down to 7. So we got twice the results using additional anabolic steroids than the champion in Europe. Now you ask, why does this work? Well, within this department, there's a Dr. Hobbs and Plymate, who in 1999 published work on what's called non-insulin facilitative transport, FIST. Now, what this does, he showed that nandrolone, better than testosterone, facilitates the movement of glucose into the cell. And if you look at a piece of
Oh,
muscle, you see that the fat is in the muscle. Insulin's only role is to push sugar into the abdomen. The other problem with insulin, it's only a one-way street. While the non-insulin facilitative transport, just by having more energy in the membrane, showed that it also will keep the blood sugars from getting too low. So the paper that I published in the textbook of bioidentical hormones showed that some of the men who were brittle diabetics using more than 100 units of insulin dropped their blood sugar the next day after the shot down to 49, but were not hypoglycemic because you have the ability of the energy to move and convert glycogen back to sugar. So this is called FIST, F-I-S-T, facilitative insulin transport. And the endocrinologists don't want to talk about it?
This is quite interesting. I coach, I do the hormone coaching myself. I worked with Women's International Pharmacy 27 years, and I have been to tons of conferences. In fact, I've even heard you. But there's a big problem with all the endocrine system when the insulin glucose is off. So that should actually be the first point of treatment, I'm thinking. Everybody's already getting pre-diabetic. You see glucose. I had a test with a woman, she was carnivore even, and her elevated glucose fasting, elevated insulin fasting. She said, how can that even happen? I have no carbohydrates past my lips, but she's into gluconeogenesis. She's losing her muscle mass, making herself a bit sicker. But this insulin resistance piece, I'm seeing it a lot when women and some men too, as they're transitioning, getting older, it's getting worse and worse, and they have more issues with many hormones.
Is if you look at what
If you look at,
we talked about with endometriosis,
yep.
same thing here. There's a lack of anabolic steroids because the environmental toxins are estrogens, and the estrogens suppress the estrogen receptor beta in diabetes and actually raise it in endometriosis. So the woman's body and those diseases affect her organs, her genital organs have a completely opposite use of the estrogen receptor beta than every other system. So gender is important. We need anabolic steroids for both men and women. The estrogen receptor beta shows us that there's a dysfunction in being able to block inflammation. When we block inflammation, lo and behold, the disease disappears. So endometriosis in women, diabetes in men, Crohn's in both diseases all respond to the proper anabolic steroid. It's almost a cure-all. After 50 years of practice, I use.
So you would let sex hormone binding globulin, if that's elevated, that would be a red flag for not enough androgen.
Definitely for both sexes.
Yeah.
And that's why it's so important, and no one else that I know of has been writing about blocking SHBG and raising the anabolic steroid. But I did that in that article. That's in the ACOG that is on the internet. Yeah. Lichten, endometriosis, ACOG, you'll see a copy of it. And that is the sample way of treating all women with hormonal dysfunction. You can use even for migraine. Okay, we found good results. I told you with one case we started with breast cancer. There's no harm in using the like libido, really strong libido.
There was a little freeze. So can you repeat the sentence you just said about libido?
Right. I have work on developing and patenting a topical cream that increases the pituitary release of oxytocin.
Mm-hmm.
That's never been done before. Most of the women report the blood and saliva shows that the oxytocin released by using this cream in the erogenous zones, breast, clitoris, perineum, is supportive of multiple orgasm and levels that are higher than a woman usually can achieve herself. Now, if she doesn't like him, it's not going to work. But if they have a positive relationship, I've used it to save a number of marriages.
Yeah.
US doctor, usdoctor.info talks about this. So that's covered 3, 4 topics.
Yes.
But it comes down to medicine really is simple. You're being poisoned, you're disrupting. I'm sorry, I'm going to have to go now.
Okay, no
Okay.
problem. We'll get
Bye-bye.
back in touch. This is perfect. Thank you.